So hello dear students, welcome to Auricle Intensive Revision Series. This is Dr. Divya, Anatomy Educator for Auricle. So here we have started with 45 days to MBBS Finals Intensive Revision Series. So here we will be doing comprehensive syllabus coverage as well as practical exam preparation and doubt clearance. And there are also mock exams included every week, which you can avail of. And why you need to choose Auricle? So here in Auricle, you get recorded classes as well as live classes. Recorded classes are at your convenience, so you can access them anytime, anywhere. We also offer you practical sessions, so you can learn the practicals as well. And there are exam modules where there are specially curated exam modules which cover the entire subject in under 20 hours. We also give you hard copy book sets of all the subjects. So where there are comprehensive notes in a question and answer, every topic is covered in a question and answer format. In recorded classes, with recorded classes, you have the flexibility of learning. Then you get expert instruction from top faculty and in-depth knowledge of the syllabus, as well as you can do the revision at your convenience. In live classes also, there is in-depth coverage of all the important topics, the past 10 years questions, as well as the most anticipated questions. And this all, you get it from experienced educators who are highly qualified. They will guide you through the concepts as well as answer writing skills, then study plans and many more. Then there are also interactive learning sessions where you can participate in live doubt clearance, MCQ polls, as well as YOC and many more. And in Express exam module. So Express exam module here, the Auricle's examination module is meticulously designed to cover the entire syllabus in under 20 hours. So this ensures efficient and effective preparation. Our expert educators, they place a strong emphasis on answer writing skills, which will help you to craft precise and high scoring responses. So the special features here are you can complete the entire syllabus in 20 hours. Then you learn the answer writing skills as well as all these things from expert educators. Then there is one-to-one doubt clearance session. So here it is a student-centric approach. So every question, no matter how small, is valued and addressed by our dedicated educators to ensure comprehensive understanding. There is personalized attention given to you, and it provides a safe learning environment so you can ask and resolve your queries without being judged. And Auricle provides a supportive and understanding setting. In practical sessions, you get hands-on experience. You can engage in interactive sessions that simulate real clinical scenarios, expert guidance from seasoned professionals with extensive practical expertise. And you can, with all this, you can excel in your practical examinations. And we also give you updated and highly effective question bank. So there are practice sessions there. So it is from beginner to expert level. Then it is a customizable question bank for better exam readiness, and it covers the MCQs for all the professional exams. That is not only the MBBS exams, but also for the competitive exams like NEET, PG and FMG. You also get the hard copy of the notes. So in these notes, there is in-depth coverage. Okay, and every topic is covered in question and answer format. All the past 10 years question papers are included. Okay, and they're all from expert educators, experienced educators who will guide you through concepts, answer writing skills, and study plans. So today's class, we'll be doing the lower limb revision. So we will be addressing some of the questions, that is long essay, short essay, and short answer questions, how to write them in the exams. So the first question is, describe the popliteal fossa under the following headings, that is boundaries, content, applied anatomy. And they've also added, describe the origin, course, and branches of popliteal artery. So always this, you need to remember, students, that whatever is asked, you need to stick to those specifically. Okay, so it is not like the quantity of the answer, but the quality of the answer that matters in the exam to score more. So in that case, so what is here? It is a long essay question, and they have specifically mentioned the headings under which you need to describe. So we will go one by one. So how do we do in anatomy without diagrams? The answer is not complete. So you need to draw diagrams for everything. So first here, before we start with the boundaries, we will define what is popliteal fossa. So popliteal fossa is a diamond-shaped depression here, which is located behind the knee joint. Okay, so this is the diamond-shaped depression located behind the knee joint. So it is analogous to the cubital fossa in the upper limb. So the boundaries. So the boundaries when we see, okay, so sometimes if you draw a neat label diagram, here only if you mention superior medially, superior laterally, inferior medially and inferior laterally, if you mention here itself, with the diagram itself becomes self-explanatory. So superior medially, it is bounded by semitendinosus and semimembranosus, and superior laterally by the biceps femoris, and inferior medially by the medial head of gastrocnemius, and inferior laterally by the plantaris and the lateral head of gastrocnemius. So the roof of it, okay, so boundaries, when we say, it includes the boundaries as well as the roof as well and the floor. So here the roof is formed by the skin, the superficial fascia and the deep fascia is present there. So the deep fascia here, it is pierced by, and the roof will also contain these structures. Okay, so we have the posterior division of so from medial to lateral, when we say posterior division of medial cutaneous nerve of thigh, then we have the posterior cutaneous nerve of thigh, the short saphenous vein, and the sural communicating nerve. So these structures are pierce the roof. So this also with the diagram you can show. The floor of the popliteal fossa. Here we have the popliteal surface of the femur, the capsule of the knee joint, the oblique popliteal ligament. Okay, this is the oblique popliteal ligament, and the fascia covering the popliteus muscle. So these structures, they form the floor. So once we describe the boundaries, the next part was the, same thing here. Next is the contents. So when we come to the contents, the main contents here are the tibial nerve, then we have the popliteal vein and the popliteal artery. Okay, in addition to that, there is popliteal group of lymph nodes and popliteal pad of fat. Okay, so these form the contents of the popliteal fossa. And towards the body, you will also see a part of common peroneal nerve. So main contents, we will talk about the nerve, vein, artery is tibial nerve. So the nerve, vein, artery, when we talk in terms of popliteal fossa, we are referring to popliteal vein and popliteal artery and tibial nerve. So these structures are arranged from above, that is in the upper part, in the middle part, and in the lower part. The arrangement differs. So in the upper part, when we see, okay, so remember AVN, artery, vein, nerve. Okay, so one direction, if you remember, the others will just follow suit. Okay, so artery, vein, nerve. So in the upper part, from lateral to medial, when we come from lateral side to medial side, it is the artery, that is the popliteal artery, popliteal vein, and the tibial nerve. And in the middle part, from superior to deep, it will be, or if we take it from the most anterior part here, okay, this will be the most posterior, it will be artery, vein, nerve. Okay, and in the lower part again, okay, artery, vein, nerve, it is from medial to lateral. Okay, so artery is more medially here, vein, nerve. So this arrangement, they ask you in the Viva also, so you need to know about it. So what is the applied aspects there? So popliteal one is, we feel the popliteal pulse. It is the most difficult pulse to feel, okay? But we can feel the pulse there. In the little lean individuals, we are able to feel the pulse. Then popliteal aneurysm, okay? So the popliteal artery is more prone for aneurysm. Aneurysm is what? It is the enlargement of the blood vessel, okay? So dilatation of a blood vessel. So that is known as aneurysm. So popliteal aneurysm, it presents as a pulsatile midline swelling in the popliteal fossa. And always you should remember, when you write the answer, the main keywords should always be highlighted, okay? So in the exams, you can't keep using different colors, but what you can do is underline the keywords. And another condition which we see commonly is the Baker's cyst. So it is a cystic cell swelling which occurs in the popliteal fossa. And why does it occur? Because of the inflammation of the synovial bursa beneath the tendon of semimembranosus, or sometimes the synovial membrane itself, it protrudes, okay, through the fibrous capsule of the knee joint there. So that causes the Baker's cyst. Next, about popliteal artery. So popliteal artery is what? It is the continuation of the femoral artery, isn't it, in the popliteal fossa. So popliteal fossa, here the femoral artery continues as popliteal artery. And at the lower end, it terminates, dividing into anterior tibial and posterior tibial artery. So what is popliteal artery? It's a continuation of femoral artery. So always artery, you will write origin, where it terminates, the course of it. If it's a long essay, short essay questions, you need to mention the course and branches. So continuation of femoral artery. So it begins in the adductor hiatus. Okay, adductor, how that is the adductor canal, no? So there. And it crosses the floor of the popliteal fossa from medial to lateral side and reaches the lower border of the popliteus, where muscle, that is where it will divide into anterior and posterior tibial arteries. So relations here, anteriorly, deep relations. There is the, so if you see here, this is the popliteal artery now. So floor of the popliteal fossa, that is here you can see, that is popliteal surface of the femur, the posterior aspect of the knee joint, fascia covering the popliteus, all of them, they form the relations anteriorly. When we say anteriorly, that will be anatomically, okay. Posteriorly, that is this side, superficial, we will see the popliteal vein, the tibial nerve, okay, the roof, that is the facial roof, superficial fascia, and the skin, basically the roof of the popliteal fossa we will see. Then the branches. Branches are divided into three groups, that is cutaneous branches, muscular branches, and articular or genicular branches. So when we say cutaneous branches, so which are the cutaneous branches? So cutaneous branches, they pierce the skin and supply the overlying skin. Okay, so cutaneous means supplying the skin. Muscular branches are many. They are also large, and the upper branches, they supply the adductor magnus and hamstring muscles, and they also anastomose with the fourth perforating artery. The lower muscular branches will supply the muscle of the, like that is the triceps surae muscle, okay, as well as the plantaris. The genicular or articular branches, they are about 5 in number. So we have that the superior medial, okay, superior medial and superior lateral genicular arteries, then inferior medial and inferior lateral genicular arteries, and middle genicular artery. Okay, excuse me. So middle genicular artery. So superior, medial and lateral genicular, inferior medial and lateral genicular, and middle genicular arteries. Next long essay question is, enumerate structures under the cover of gluteus maximus. Describe in detail the sciatic nerve and its applied anatomy. Okay, so first you need to enumerate the structures. Okay, so just you have to name the structures. So when you are naming the structures, to give a better impression and score better, you need to mention which are the bones, which are the joints, which bursae, which muscles, which nerves, which vessels. So if you group them and write the answer, it will have a better impression. And you can also write it in the form of a tabular column. Then you have to describe the sciatic nerve and its applied anatomy. So any nerve, the origin, the root value of it, the termination, course, relations, branches, applied anatomy, you need to, because they are not specified, they have said describe in detail the sciatic nerve. So structures under the cover of gluteus maximus. So you draw a diagram showing all these structures, a sectional diagram. And with that, you can write it like this. So muscles. So all the muscles of the gluteal region except the tensor fascia lata, reflected head of the rectus femoris, then all the hamstrings, origin of hamstrings, and upper fibers of adductor magnus. Okay, insertion of the upper fibers of adductor magnus. All this lies under the muscles. Vessels, superior and inferior gluteal vessels, internal pudendal vessels, trochanteric arterial anastomosis, as well as cruciate anastomosis. Okay, Now, superior and inferior gluteal nerve, sciatic nerve is there, posterior cutaneous nerve of thigh, then nerve to quadratus femoris, pudendal nerve, nerve to obturator internus, and perforating cutaneous nerve. Joints and ligaments include hip joints. So basically, you would have seen it during the dissection and all, whatever structures come there. So you have to have a mental picture with this diagram. So what are the structures coming there? And in an order, you need to remember and write. Okay. So joints include hip joint, sacroiliac joint, sacrotuberous ligament, sacrospinous, ischiofemoral ligament. Bursae include trochanteric bursa and ischial bursa sometimes, and gluteofemoral bursa. Coming to sciatic nerve. Okay, so sciatic nerve, the root value is L4 to S3, L4, L5, S1, S2, S3. So it is the thickest nerve in the body, and it is the nerve of the posterior compartment of the thigh. So it arises in the pelvis from the ventral rami of L4 to S3 spinal nerves. So a little above the popliteal fossa, okay? So it terminates where? A little above the popliteal fossa. That's the junction of the middle and lower thirds, okay? That is in the back of the thigh, okay? Just above the popliteal fossa. It will divide into its terminal branches, that is the tibial and common peroneal nerves. So first, once you write this, next is the course. So it leaves the pelvis through the greater sciatic foramen below the piriformis, so that is its normal course, okay, and enters the gluteal region. So there it descends between the greater trochanter and the ischial tuberosity. Okay, first between the greater trochanter and the ischial tuberosity. Greater trochanter of the femur, ischial tuberosity of the hip bone. So there it will descend. And just a little above the popliteal fossa, it will divide into tibial and common peroneal nerve. Okay. So here the deep relations means these relations, they form the bed of the sciatic nerve. So sometimes for a 3-mark question, the bed of sciatic nerve can be asked. So nothing but you need to write the deep relations. So here, what do we have? If you start from here, there is the body of the ischium, then obturator internus with the superior and inferior gemelli muscles, quadratus femoris muscle, then this is the adductor magnus muscle. Okay, so they form the deeper relations of the sciatic nerve. The superficial relations include the gluteus maximus muscle, then the this thing, what is this? Biceps, long head of the biceps femoris. Branches. So sciatic nerve, okay, it has its two components, that is the tibial component and the peroneal component, common peroneal component. So through its components, it gives branches supplying the muscles. So all the posterior compartment muscles, they are supplied by the sciatic nerve. So here, the tibial component supplies the hamstring group of muscles, which include semitendinosus, semimembranosus, long head of biceps, and adductor magnus. So these four are supplied by the tibial component, whereas the short head of the biceps femoris, okay, it is supplied by the common peroneal component. So as you can see here, all the branches are given on the medial side, whereas on the lateral side, there are no branches. So that is why we use the lateral part of the thigh to give the intramuscular injection. So it is safe region. So applied anatomy, so sleeping foot. So sleeping foot, what happens is, the sciatic nerve on the back of the thigh, it is basically a little bit uncovered. Okay, uncovered in the sense there is no, it lies a little superficial. That is between the lower border of gluteus maximus and long head of biceps femoris. Okay, so which we saw here. So this portion, it is slightly uncovered. Okay, so this is what they mean. So here, that part, it is subjected to compression, especially when you sit at the edge of the table. Sorry, it's a chair. Okay, when you sit like that, that time that part comes in contact with the hard surface and it compresses. Okay, so that will cause paresthesia in the lower limb. So that is called as the sleeping foot. Then injury of the sciatic nerve. So basically the sciatic nerve can be injured by penetrating wounds, posterior dislocation of the hip, fracture of the pelvis during total hip replacement surgery, which is quite rare, or sometimes a misplaced therapeutic injection. Okay, so without knowing actually the anatomical location, if you just give the injection, then the sciatic nerve can be injured. So what will happen? There is motor loss. Okay, so basically there is inability to extend the thigh and flex the knee due to paralysis of the hamstring muscles. There is loss of movements below the knee with the foot drop due to paralysis of all the muscles of the leg and foot, because the muscles of the leg and foot are supplied by the branches, that is terminal branch of the sciatic nerve. So motor loss will lead to flail foot, which leads to difficulty in walking. Okay, so they will walk like high stepping gait. So they are not very sure where their feet will touch next. So they have that high stepping gait. Sensory loss will be there on the back of the thigh and the whole of the leg and foot, except the area which is innervated by saphenous nerve. Okay, because of the involvement of the cutaneous nerves derived from the tibial and common peroneal. So these are the things. Then other conditions which we see is sciatic nerve neuropathy. So here what happens, as the sciatic nerve leaves the pelvis, sometimes it usually leaves by passing below the piriformis, but sometimes it passes through the piriformis and it may become entrapped, leading to piriformis syndrome. Okay, so it is anatomically commonly we see that, but entrapment neuropathy is a little rare. Sciatica. So it is a clinical condition where there is shooting pain felt along the course of distribution of sciatic nerve. So usually in the buttock region, the posterior aspect of the thigh, the lateral aspect of the leg and dorsum of the foot. So it occurs due to compression and irritation of L4 to S3 spinal nerve roots by herniated intervertebral disc. Okay, so disc compression can lead to herniation and compression of the nerves there. Coming to short essay questions, adductor magnus muscle. So any muscle, origin, insertion, nerve supply, action, and if it is it has a particular applied aspect or clinical importance, you need to mention. So adductor magnus is a composite muscle. Composite when it has nerve supply, or a hybrid muscle we say, where it gets a double or dual nerve innervation. Okay. So it consists of adductor part and a hamstring part. So the adductor part arises from the outer surface of the istiopubic ramus, that is from the ramus of the ischium, whereas the hamstring part arises from the inferolateral part of the ischial tuberosity. Okay. So you can see here from the adductor part from the ischium and hamstring part from the istiopubic ramus. So where does it get inserted? The adductor part, it gets inserted into the medial margin of the gluteal. So along the gluteal tuberosity, the linea aspera and the medial supracondylar line, the entire length. Okay, so extending from the gluteal tuberosity to linea aspera and medial supracondylar line, it gets inserted. Hamstring part gets inserted to the adductor tubercle. Nerve supply, adductor part is by the posterior division of the obturator nerve, whereas the hamstring part is by the tibial part of sciatic nerve. Actions, it brings about, it is the muscle of the adductor compartment also, right? So there it brings about adduction and medial rotation of the thigh. Hamstring part is a weak extensor of the thigh at the hip. But they are, since it is attached to the femur itself, that is adductor tubercle of the femur itself, it doesn't bring about the flexion of knee joint, because otherwise the hamstring muscles, their action is flexion of the knee joint also. Next question is piriformis muscle. So again, muscle, same thing, origin, insertion, or supply, action. So piriformis is a triangular muscle, okay, triangular muscle, which is present one on either side on the front of the posterior wall of the true pelvis. So it arises from the pelvic surface of the middle three pieces of the sacrum by three digitations. Okay, so by like a 3 only it is. By three digitations, it arises. So the fibers here, they converge inferolaterally. Okay, they are converging inferolaterally and they pass through the greater sciatic notch and enters the gluteal region where they form a rounded tendon which is inserted to the tip of the greater trochanter. So it is supplied by the ventral rami of first and second sacral nerves. Action, it stabilizes the hip joint and it is a lateral it helps in the lateral rotation of the femur when the hip joint is extended. Okay. And acts as an abductor when the joint is flexed. Okay. So when the joint is extended, it will help in lateral rotation. Whereas when the joint is flexed, okay, it helps in the abduction. Next question is common peroneal nerve, or it's also called as lateral popliteal nerve. So origin, course, and branches. Okay, so the same thing. So the common peroneal nerve is the smaller terminal branch of sciatic nerve. So the root value being L4, L5, S1, S2. Okay, it arises in the lower third of the thigh. Okay, you can draw like this a line diagram showing its course and branches in the different regions. Now this is in the popliteal fossa where it is given. This is the leg and the foot. Okay, so you can see like that and right. So it's a common, the common peroneal nerve is a smaller terminal branch of the sciatic nerve, root value being L4, L5, S1, S2 and S1 and S2. So it arises in the lower third of the thigh just above the popliteal fossa and ends by dividing into two branches. Okay, one is the deep peroneal, another one is the superficial peroneal. So this passes into the popliteal fossa along its upper lateral boundary. Okay, so just beneath that is edge of the biceps tendon. Then it runs, okay, then it runs over the plantaris and the lateral head of the gastrocnemius. Okay, gastrocnemius muscle and over the fibular attachment of the soleus. Okay, it runs over the fibular attachment of the soleus and binds around the lateral aspect of the neck of the fibula. And it reaches deep to the peroneus longus, where it will divide into terminal branches, that is the deep and superficial peroneal nerves. Okay, so it is given in the popliteal fossa. So along the lateral boundary, it will run. Okay, just beneath the lateral boundary, in the upper part, superolaterally is formed by which muscle? By the biceps muscle. Okay, so it runs beneath the edge of that biceps tendon. Then after that, when it comes to the inferolateral part, which muscles are there? The plantaris and the lateral head of the gastrocnemius are there, forming the boundary of the popliteal fossa. So it runs over that, okay? And after that, then it turns it goes over the fibular attachment of the soleus muscle and winds around the lateral aspect of the neck of fibula. So that region, no, this common peroneal nerve, it can be felt, especially in leprosy. Lepromatous leprosy, there is nerve thickening. So in that condition, this nerve is thickened and we can feel it near the neck of the fibula. Okay, so it reaches deep deep to the peroneus longus. And after that, it will go deep to the peroneus longus, where it will divide into terminal branches, that is deep and the superficial peroneal. So the deep peroneal branch, supplies all the muscles of the anterior compartment of the leg, okay, including the extensor digitorum brevis, okay, on the dorsum of the foot also, it will give a branch. Whereas the motor branches of the superficial peroneal nerve, they will supply the muscles of the lateral compartment. Lateral compartment muscle is peroneus longus and peroneus brevis. The sensory branches of the deep peroneal nerve supply the skin of the cleft between the great and the second toe. Whereas the sensory branches here of the superficial peroneal nerve, they will supply the skin over the dorsum of the foot, okay, entire dorsum of the foot, except the cleft between the great and the second toe, okay. So the commonest site of common peroneal nerve injury is near the neck of the fibula. Okay, so it is vulnerable to injury there. It can be injured by direct trauma, fracture neck of the fibula, or sometimes a tightly applied plastic cast. So the characteristic clinical features here are, one is motor loss. Okay. So because of motor loss, what will happen? There is foot drop. It is supplying all the muscles, right? That is of the anterior compartment. So they are the dorsiflexors. They keep the foot up like this, dorsiflexion. So when dorsiflexion is not there, the foot drops. So that is known as the foot drop. So there is loss of extension of the toes because of the paralysis of extensor digitorum longus and hallucis longus, and eversion of foot is lost. Okay, eversion is lost. Eversion is inward like this. So it is because of the peroneus longus and peroneus brevis. Okay, they are the everters of the foot. Sometimes this, which are the everters of the foot, is asked like a MCQ question or an 3-marker question. Sensory loss is on entire anterolateral aspect of the leg and dorsum of the foot. Okay. So except on the medial and the lateral side of the foot, which is supplied by the saphenous nerve and the sural nerve. Next, coming to short answers, obturator nerve. So obturator nerve, the root value muscle supplied is asked. Okay. So just briefly, you mentioned about what is it? Is the nerve. Obturator nerve is the nerve of the adductor compartment of the thigh, arises within the psoas major muscle from the anterior divisions of ventral rami of L2, L3 and L4. So it divides into anterior and posterior divisions, that is near the obturator foramen. So the motor branches will supply all the muscles of the adductor compartment of the thigh. Okay. Sensory branches will give the lower half of the medial aspect of the thigh, and it also gives articular branches to the hip and knee joint. So usually any nerve will have cutaneous branches which will supply the skin, muscular branches supplying the muscles, articular branches supplying the joint, and vascular branches supplying the blood vessels around there. Okay. So, so you should see any nerve, you should think about these branches. Excuse me. Think about the branches and see whether it is giving any of these. So injury of the obturator nerve. Okay, so obturator nerve is injured in anterior dislocation of the hip joint or during radical retropubic prostatectomy. Okay, so motor loss will be there. So since it is supplying the adductor muscles, there is loss of adduction of the thigh. Then sensory loss is there on the medial aspect of the thigh because of the involvement of cutaneous branch of the anterior division of obturator nerve. So the anterior division will give the sensory branch, will supply the lower part, okay, of the medial aspect of the thigh. Then so if it is a short essay question, you mention everything in detail. But if it is a short answer question, you just need to write the headings. That will be more than enough for a 3-mark question. Yes, since this question can be both, I have just explained in detail, though it is a 3-mark question. So obturator nerve neuropathy, here, this is caused because of the nerve entrapment. So this will cause medial thigh pain, usually seen in athletes, okay, with large adductor muscles. Surgical division of obturator nerve is done to relieve the spasm of the adductor muscles in spastic paralysis. So inflammation of the ovary, okay, causes localized peritonitis in the region of ovarian fossa, and that can cause irritation of the obturator nerve. So because of that, there will be pain and tingling sensations where it has the cutaneous subtype. Referred pain. So in the diseases of the hip joint, the pain may be referred to the medial side of the thigh. Next is cruciate anastomosis, so formation and applied aspects. So it is a very important question asked in so many past years. So first is, what is this? What is cruciate anastomosis? So this cruciate anastomosis, okay, it is situated in the upper part of the back of the femur at the level of the lesser trochanter. So this cruciate anastomosis is formed by the following arteries, that is transverse branch of, so if you can see, this is the cruciate anastomosis. So it is formed by the transverse branch of medial circumflex, transverse branch of lateral circumflex, ascending branch of first perforating, and descending branch of inferior gluteal artery. Okay, so these forms the cruciate anastomosis. So what is its importance? It provides a collateral channel for blood supply to the lower limb by bypassing the external iliac and femoral artery. So if there is any blockage here, this will help in the collateral supply. Okay, so for example, in ligation of femoral artery, so in surgeries and all, when you ligate the artery above the origin of profunda femoris, it will maintain a efficient blood supply through the collateral circulation. Next is foot drop. It's a very important question. So you have to answer like, what is foot drop? What is the cause for it? What are the clinical features of it? So foot drop, it occurs due to injury of the common peroneal nerve. Main, isn't it? You can also say deep peroneal. But since deep peroneal is a branch of common peroneal, we take it as common peroneal. So it may be injured by the direct trauma, fracture neck of fibula, or tightly applied plaster cast. So characteristic features here will be foot drop. So because of the paralysis of muscles of the anterior compartment of the leg, which act as the dorsiflexors. There is loss of extension of the toes because of paralysis of extensor digitorum longus and extensor hallucis longus, and loss of eversion of foot because of paralysis of peroneus longus and peroneus brevis, which are the everters of the foot. So with this, we complete today's class. Okay, so thank you for watching Auricle. So you can make use of the mock tests which are offered by Auricle. So it's during every Sunday, you will have the mock test. And if you haven't yet downloaded the app, you can get it on Google Play Store, or the Apple Store, and you can download the app and start your journey with Auricle. So until then, next time.